growth and destruction. Osteoclasts are breaking it down, blasts are making it. So just real generally, we're going to talk about bone growth. There's a couple different forms of developmental bone growth that are listed up there. I'm going to talk about the fact that it's also bone is continuously growing, like I mentioned at the end of the lecture. Specific term for this called appositional growth. Then we'll talk about some effects of bone growth with aging. And somewhere along the way, we talked about fractures and repair of bone. So those are all categorized under bone growth. The main form of bone growth is called endochondral bone formation. Right? And chondro refers to cartilage. Chondrocytes make cartilage. So what that means is, generally, bone doesn't just start growing. There needs to be something there for the bone to grow on, right, with all of these examples. Right? So the main form is endochondral, where there's a cartilaginous precursor to the bone, and then the cartilage gets replaced with bone. So we'll talk about the details of that mainly. I wanted to mention this. Your textbook goes into some of the details of intramembranous bone growth. It's actually fairly complicated. I'm not going to get into the details of it, other than what I want you to know, which is it's generally kind of similar. Bone just doesn't form, and it's mainly in these bones here, the big flat bones, some of these other flattish bones of the skull. The clavicle also happens to be one bone that's made by intramembranous bone growth. And it's not, and the distinction is that it's not a cartilaginous precursor. It's a dense, regular collagenous connective tissue that's laid down first, and then that gets, that's what gets replaced. The term that's associated with this, I think I have it somewhere for the intramembranous. Is that it's woven bone, and it has to do with what the bone tissue looks like under a microscope. So intramembranous bone is initially made by ossification of dense connective tissue with this woven bone, and I'm not going to get into the details of what it actually looks like. I just want you to be aware of the term, because it relates to bone healing after a fracture. You'll also see this woven bone type of material. And the reason it's called woven is that there's really no organization. It's just basically a bunch of osteoblasts in there laying down matrix in a real disorganized pattern, right? Kind of think dense, irregular connective tissue, how everything's just kind of laid down there in kind of an irregular, or it's really the basis for the term woven. And then that gets replaced and continuously remodeled into the more organized structure of compact bone on the outside of the flat bones and the trabecular nature of the inside of membranous bones. So the other general point is that looking at an adult bone, you can't really tell whether it was initially made by endochondral bone formation or intramembranous bone formation. There's this remodeling that takes place after, kind of alongside with the endochondral bone formation, and this remodeling that happens to the intramembranous bone formation that make them look fairly similar. So endochondral bone formation, again, it's not just long bones. Almost every long bone, except the clavicle, is made this way. But some of those, like the bones of your wrist and stuff, are laid down with a cartilaginous precursor first. Right? And then there's two different centers of ossification. right? There's the primary center of ossification, which starts in the middle. Let me just pull up other pictures so that you can kind of see it. Well, this primary center of ossification is actually stimulated by the blood vessels that grow into the area. Remember, cartilage is an avascular tissue. It can form developmentally without the vasculature. And when the vasculature comes in, it stimulates initially, typically in the center of a bone, a primary ossification center, where the cartilage is basically just replaced by bone matrix from osteoblasts. So, pretty simple. We're not going to get into a lot of the details. We'll talk about the details of what happens at these later stages of development. But basically, osteoblasts move in due to the blood vessels, and they start to synthesize bone material. Osteoclasts are actually important in destroying the cartilaginous precursor, breaking down the cartilage and allowing the osteoblasts to form their osteoblasts to start forming bone. So this kind of goes from a central towards a peripheral section of the bone. And then you get these secondary ossification centers. So the secondary ossification centers, well, you can just write it down, right? The secondary ossification centers are what actually form the epiphyses. Right? The epiphysis is the end of the bone. Right? This is an epiphysis. I found this on my floor this morning. Somebody brought a bone for my dog, right? Epiphysis, right? It's started ossifying here, right, in the central part of the epiphysis. Hold it upside down. It's a femur. In case you didn't, I should have tested you on that. Right, started ossifying here. The main shaft here started the primary ossification center was here where my hand is. And those two start to grow together. So the main type of bone growth that we're going to focus on is this here. The mechanism is pretty much the same as where it started out. The primary ossification is cartilage that slowly gets replaced by bone. But again, in order to make bone, you need a cartilaginous precursor. So what's happening here, right, at the ends of the diaphysis and on this side of the epiphysis, actually you get bone growth all the way around the epiphysis, right? But we're going to focus mainly here, kind of on that epiphyseal plate. So embryologically, developmentally, all the way through puberty for some bones, all the way through puberty, there's these epiphyseal plates. Right? That's what got broken here. Good Lord, my dog got that huge bone and actually, was able to chew it in half. It just showed up in our house last night. Right? No, the dog didn't chew it in half. This is a weak spot in the bone. Right? I mean, think about what a cow, because they don't let them get fully, they probably don't go all the way through puberty before they slaughter them. Right? So the cow still had, actually this happens to be on the other end of the bone. Right? This is the proximal end of the femur here. Right? But there's this epiphyseal plate, which is still growing cartilage in there. When it completely fuses, it leaves these remnants called epiphyseal lines, which you've probably seen. Yeah, I think I pointed these out with some of the other adult bones that we've looked at. Right, and this is so cool. It's not, I always thought it was a nice flat line. It's not a nice flat line. Big irregular pattern to the whole epiphyseal plate. Right, so, so think about it. This is two bones. Actually, here, the femur is a little bit weird because it has a couple, right, the femur, the proximal end of the femur actually develops from three, or if you look at the distal end, right, four separate bones that fuse together. Not completely unlike the development of other bones that grow together and fuse and form a complete bone, right? Mandible develops from two separate bones that grow together. Okay. This is actually pretty complicated. This, just kind of a warning. It kind of makes sense, or hopefully, let me know if it doesn't. It kind of makes sense as I go through it, but just, write yourself a note that you're going to have to come back and study it, because the direction of where the growth is actually happening and where the bone is forming gets a little bit confusing. Right? Realize what we're zoomed in on here. Right? We're looking at just a little part of the epiphyseal plate. So it's really just this, right? This is the top of the bone or the proximal end. We're really just looking here kind of at the distal end, the distal end of this epiphyseal plate. Okay. Right, and we're looking at how the bone is actually formed. The bone doesn't, well, one way to describe it is the bone doesn't grow, the cartilage grows. Right? The cartilage continuously grows, and then the cartilage continuously gets replaced by bone. So the cartilage is actually growing here. Right? And that's what you see right here. Up here is resting cartilage, that's already here. Right about here, oh, they've got it labeled right here. This is better. Okay. Right about here is the, oh, okay, so it's down here. So right about here is where the chondrocytes are dividing. Right. So the zone of proliferation is where the chondrocytes are dividing, adding more and more chondrocytes. This is where really bone growth is happening, right? How you get a longer bone is right here in the proliferative zone. Right? And what that means is that the epiphyseal, you can think about it as the epiphyseal plate getting bigger and bigger, longer and longer. But what happens is down here the chondrocytes are hypertrophying, right? Hypertrophy just means that they get bigger and they synthesize a lot of the extracellular matrix, right? The collagen, mainly the collagen and proteoglycans that are in the extracellular matrix, right? And then down here you have the osteoblasts. So these are representing osteoblasts and osteoclast cells, right, that are going to be destroying the cartilage that is laid down and replacing that with bone tissue. Does that make sense? I think it's pretty straightforward, but you kind of, when you look at this, you kind of think, oh, the bone's all, it's growing down here. Yeah, but what's happening up here is the cartilage is actually growing, right, and slowly getting replaced by the bone tissue. Right? Therefore, the bone ends up getting longer. So the other thing, it should be kind of obvious, but just in case it's not, you're just looking at one end of one bone. Right? The same thing is happening on the distal end of the bone. Right? They're growing from both ends. And, right, the epiphysis is getting bigger. This is a wonderful visual. I just kind of brought this in because I thought it was kind of gross and goofy, but this is a big bone. Right? Embryologically, it wasn't that big. So there's continuous growth all the way around the epiphysis as well. There's more growth right here where we're kind of focusing on it here, right? Kind of on the diaphysis side of the epiphyseal plate. There's more growth there, but there's a significant amount of growth at the all the way around the epiphysis. So that's the two different forms of developmental growth. There's continuous growth of bone tissue. Yeah, you can call it growth. It's really, you know, what I said to continuous remodeling of bone. And this is different than intramembranous and endochondral bone formation, because what happens with appositional growth is that the bone tissue itself acts as a substrate for the growth or destruction of new bone. Right? Again, you don't just make bone out of nowhere. Bone has to be laid down on something else. It can be dense connective tissue, can be cartilage. Appositional growth, the type of growth that's happening throughout life, is bone growing on existing bone tissue. So that's going to involve osteoclast activity as well as osteoblast activity. And it occurs in both places. So when you think, you know, developmentally, yes, the bones are growing in length, right? But obviously, the bone of a young child is only, you know, even the femur bone of a young child is only this big around. It gets big, the diaphysis gets bigger as you go through childhood. So this appositional growth is happening kind of in sync with the developmental growth. So it's happening along the diaphysis, right? And this appositional growth is what gives the diaphysis its real dense structure, right, with no trabeculae. Early in development, and even in children, there's young children, along the marrow cavity of compact bone, there's a significant amount of trabeculae in there. Those continuously get remodeled, right, to make just the compact bone on the diaphysis. And more importantly, right, these trabeculae are incredibly dynamic. And they're always responding to the stresses that are put on them, and adding new bone where stress is detected. Really don't, the biomechanical physicists are really trying to figure out what's actually detecting bone stress. There's probably some nerve fibers that are detecting it, but other people think that the osteoblast cells, or maybe it's the osteoclast cells, can somehow detect when there's stress on a bone and know when some bone can be destroyed or other bone can be laid down. And the trabeculae are what's really being continuously remodeled. And I've got my slides in order. No, I don't have my slides in order. Right, this just is kind of an example of how stresses, I mean, femur joint, or the proximal end of the femur is a really good example, because there's all these weird lateral and torsional strains that are put on it because of the way the head of the humerus fits into the acetabulum. There's all these weird stresses, right, that need to be continuously sensed. Again, we don't really know how it's sensed, but it's clear that the trabeculae are kind of laid down where these main levels of stress are placed on it. Hormones and nutrition feeds into that. I'll come back to that. In a minute, but that's actually kind of a good segue into talking about these things that are affecting bone growth. Yeah. Let me just give you, it's worth writing down the main hormones that we're gonna talk about. Some of these other hormones are related to bone growth during development. focus on kind of a little bit of the details. And I should kind of caution. This is an oversimplification, but I think if you kind of get this, calcitonin is a certain hormone that's involved in increasing bone mass. Actually, the oversimplification is that it's not directly controlling how much bone you make or not. It's really, both of these hormones are more just involved in calcium metabolism, or calcium homeostasis. But if you just kind of get this general thing into your head when we start talking about them specifically. So you can see the thyroid gland here, which is part of this whole system. And what I want to introduce is the pituitary gland. Again, you're going to get into that probably at the end of this class, at the end of 355. So pituitary gland is hanging off the bottom of the brain, sitting. You guys know where it sits? Sella turcica, right? That's why there's a little divot there in the sella turcica, because the pituitary gland happens to be sitting right there. Pituitary gland is really complicated. It's secreting lots of different things. One of the things that it's secreting is growth hormone. So what growth hormone does is to increase muscle mass as well as bone mass, right, continuously throughout life, but really early in life. Growth hormone is stimulating bone growth when bones are initially forming, stimulating those epiphyseal plates. So one of the substrates of growth hormone is going to be those chondrocytes, right? The chondrocytes that are laying down bone. And you guys probably know, we're going to get into talking about aging. Postmenopausal women have problems with bone maintenance, right? So the sex hormones are also involved, estrogen and testosterone. Pituitary gland is also involved in that because it's stimulating. So really, lots of stuff on here. We'll come back to these. Right? But this is one of the axes that the pituitary gland is regulating bone. Not directly. Pituitary gland is regulating the ovaries to secrete estrogen, regulating the testes to secrete testosterone. More directly, regulating bone growth through growth hormone activation, right? And there's also these specific hormones, which are the ones that I listed up there, right? But you can see how the pituitary gland is involved in at least one of those, right? The pituitary gland regulates the thyroid. Part of what the thyroid does is to secrete calcitonin, right, which is involved in bone maintenance. Okay. Obviously, vitamin D and get right into that. Vitamin D and calcium are also involved. Right. We talked about where vitamin D is synthesized. We didn't get into all the details, but remember what's important for vitamin D formation if you don't get it in your diet? Skin. Right? Cholesterol precursors are made. They're absorbed by keratinocytes. UV exposure converts them into vitamin D precursors, and then you can make vitamin D. If you get plenty of vitamin D in your diet, you're fine. Right? But also, obviously, calcium is involved. So I want to just say a few things about the parathyroid hormone from the parathyroid gland and calcitonin, which comes from the thyroid gland. Sorry, again, my slides are a little bit out of order. I don't know how all this happened. So when before we talk about the details of those, just to give you an orientation of where these glands are in the body. Again, this is kind of a good example of what the endocrine system is. Right? The endocrine system is a whole bunch of glands spread out all throughout the body that are doing these things that don't really seem like they may go together. Right? So you've got these glands in your neck. Right? They're right here. You know where your voice box is, where your Adam's apple, kind of wrapped around that. It should be pretty obvious. This is the voice box of the larynx. Right, thyroid gland is right in front of that, kind of wrapped around it. This is a view from the posterior side. Right, so this is thyroid gland tissue, and embedded in it are this separate glandular tissue called the parathyroid. So what stimulates well, we'll talk about the parathyroid gland first. Right? Generally, parathyroid, kind of like I've got, I think this might be a little bit confusing, that's why I kind of gave you kind of the shorthand. Right? Parathyroid hormone is going to lead to decreases amount of bone. But what's really stimulating it, right, is calcium in the blood, the concentration of calcium in the blood. So parathyroid glands, or I'm sorry, parathyroid cells have receptors on them that aren't kind of what you might think of as normal receptors. Receptors you think of as a transmembrane protein that has some extracellular domain that's responding to a neurotransmitter or a hormone that's in the blood. Parathyroid cells are directly responding to the amount of calcium, and they're always continuously regulating how much parathyroid hormone they secrete or how much or don't secrete. So the parathyroid hormone cells respond to that. So if you have an increase, right, in calcium in the blood, or they respond to increases in calcium that are present in the blood. Right? What that means, theoretically, right, is the osteoclast activity hang on. Don't you hate that when you get stuff backwards? Oh. Hopefully I didn't go far enough that I confused you all. Actually, what they respond to is a decrease in calcium in the blood. Right. So this is actually the main stimulation for parathyroid gland, right, is a decrease in calcium in the blood, right, which leads to the parathyroid cells secreting parathyroid hormone. What that's going to do is increase the activity of osteoclasts, which is going to increase calcium, is going to compensate and increase calcium in the blood. Parathyroid hormone also has these other functions to help use the increased calcium. Right? It increases the synthesis of vitamin D, right? And also stimulates the kidney to help resorb more calcium. So if there's low calcium in the blood, one of the effects of parathyroid hormone is going to be increase the reabsorption of calcium in the urine, from the urine, so that it's not lost. So that's mainly, that's pretty much the only thing that the parathyroid gland is doing, is responding to calcium, right? And it's basically a matter of how much calcium is present. Right? The problem is, it's regulating osteoclast, right? And this main stimulus here, right, may or may not be due to the overactivity of calcium. Right? If you just have low calcium in your diet, right, your parathyroid gland kind of thinks that your osteoclasts aren't working right and starts to stimulate it. Right? So it's really, when you think about these glands, you know, we kind of got you thinking about them as regulating bone. Really what they're doing is using bone to regulate the amount of calcium that's in your body. Thyroid gland is basically kind of regulating that in the opposite direction. Thyroid gland does some other things. It releases thyroid hormone, which doesn't have anything to do with bone directly. Right? But one of the hormones that's secreted from the thyroid gland is called calcitonin. There are cells that similarly, right, respond to calcium. Right? And those cells release calcitonin, which basically does the opposite. So osteoclast activity is regulated, you know, in two different ways that might make you think that it's really easy to regulate osteoclast activity. Right? What we're going to end up talking about is, you know, therapies. You would think, based on this, that it's real easy to regulate osteoporosis. Right? Well, you know, there's lots of different forms of osteoporosis, but one of the forms that's real common is postmenopausal women, right? Have decreased calcium in their blood. What do you want to do? You want to decrease osteoclast activity, right? So either find a drug that blocks parathyroid hormone, right? Or give them calcitonin. That's pretty simple to do. It doesn't work. You know, those are some of the initial therapies that they tried for osteoporosis. Calcitonin therapy, because there's these multiple levels of control, we don't really know why. Probably because there's these multiple levels of control, that just giving somebody calcitonin, right, doesn't necessarily decrease osteoclast activity. These other mechanisms kick in, right, and start to compensate for that. Okay, kind of got ahead of myself and started talking about osteoporosis. The other deficiency that you've probably heard of, but anybody know anybody that's had rickets? Right. It's not a big problem in developed countries where there's tons of vitamin D and every milk and other things that you get. But actually, this vitamin D synthesis can be a problem. Right? It's probably mainly in children, in countries where children are malnourished. They probably don't get enough calcium in their diet, but mainly they don't get enough vitamin D in their diet, right? Which leads to this condition of rickets. This is probably the most obvious example of what decreased amount of vitamin D and calcium can lead to. Right? You'll notice you know, this is basically just these really extremely bowed legs. Right? And what this means, if you're familiar with looking at radiographs, right, you should notice that you can hardly, can you see the femur and tibia from back there? No, this is, actually, if you look on Wikipedia, you can see them. You can actually see them, right? But the point is, there's not a lot of mineralization in the bone there, right? Lots of collagen, the bone cells are working fine as far as laying down collagen, right? But what gives bone its hardness? The calcium phosphate salts, right? And vitamin D is required for taking up the calcium in the diet. So even if they probably have calcium deficiencies anyway, right? But it's mainly the vitamin D deficiency, so that the calcium can't get absorbed and can't get incorporated into bone. Right? You see this bowing, basically all the bones are going to be like this, but the reason why you get this diagnostic sign of the bowed legs is because they're bearing a lot of weight. Right? So they basically, instead of growing straight, because there's stress on them, continuous stress on them, they do ossify, right? But they start bending as they're ossifying. Right? And if this isn't corrected, the patients are going to have these malformed legs for the rest of their life. The other sign that you can see from really it's lack of calcium in the bone, right? But the lack of calcium is caused by vitamin D. Okay? Is in the wrist joints. You see this at mainly at the epiphyses. This is actually at the malformation is actually at the epiphyses of most of the long bones. Right? It happens to be most obvious here in the wrist for some reason. So this is a diagnostic tool where the wrist gets really swollen. Right? Looks like there's too much, right? Yeah, too much bone. Well, no, the problem is they can't make bone. Why is the wrist swollen? Right? It's the epiphyseal plate gets spread out there, right? What's happening at the epiphyseal plate? Lots of cartilage is being laid down. It's not being replaced by bone as much as it should, so you get this hypertrophy of the cartilaginous part of the epiphyseal plate, right? Because you don't have enough calcium, because you don't have enough vitamin D, you don't have enough calcium to actually add the bone there. So again, you see this diagnostically for some reason at the wrists a lot more, but it's happening, the ends of most of the long bones. If you're good at looking at radiographs, which I'm not, right? Theoretically, you can kind of see it here at the carpal, the metacarpal joints as well, where the epiphysis is kind of splayed out. Ribs, there's also a diagnostic tool of the ribs, or just a diagnosis that you can make just from looking at someone's chest cavity. Okay. So we're going to talk about this continuous bone remodeling, and again, this is the kind of thing, these are the kind of areas where you're going to see this continuous bone remodeling, where in the adult, parathyroid hormone and calcitonin are having their effects, right? But sorry, we'll come back to bone repair. So what you see, because of the hormonal influences, and what you see typically, you see it in older people in general, but more commonly in postmenopausal women. This actually isn't the greatest example, but you can see how the trabecular network here is really following the stress lines that you would see here. Right? What leads to these common fractures, right, is that the trabecular network hasn't been responding appropriately and hasn't been laying down bone appropriately. And the main effect is here on the cancellous bone in the trabecular network near the ends of the bone. So you commonly see fractures in older people, and also in postmenopausal women. So, like I was saying, calcitonin, right? So just, give them calcitonin. Decrease, I mean, obviously this is a problem with osteoclast activity. What people have found out is that the regulation, there's this kind of hormonal regulation, but there's also this internal regulation where osteoblast cells and osteoclast cells are regulating each other in a way that compensates, right? So if you get lots of calcitonin, right, which is going to decrease osteoclast activity, it can also actually decrease osteoblast activity. There's therapies. People have heard of Boniva and, I'm going to say it wrong, so something begins with an F, right? What's it called? It is Fosamax? That's what I was going to say. I was thinking that was a nasal medicine. Yeah. Boniva and Fosamax are all this classification of drugs, which are called bisphosphonates. Right? Estrogen therapy seems to work almost the best, at least in postmenopausal women. Right? Calcitonin doesn't work very well. Calcitonin replacement. The bisphosphonates came out. I don't know why I have all these words in here, right? But this is just one of the forms of bisphosphonate that's called Boniva. Right? It's really clear in laboratory studies, in animal studies, that these drugs act directly on the osteoclasts and decrease the osteoclast activity. That's kind of what's written all in here. Right? It seems like a really good therapy. And it does. It does work in some women some of the time. But what people still haven't, I mean, even though this stuff is standard stuff that's in the textbook, and you think it's real easy to dissect out, right? People on these drugs end up getting a lot of broken bones. Right there, it's Fosamax. I don't know if Fosamax has been recalled, but the use of Fosamax has been more tightly controlled. When you're on these drugs, especially for long terms, which is the type of therapy that would typically be used in aging people, because of this interaction that people still don't really understand, if you decrease osteoclast activity, you're also, at least in some parts of the population, you're going to be decreasing osteoblast activity, right? So you might get less bone destruction, but you also get less bone growth. Right? And what's important for this continuous remodeling, right, is the continuous bone growth. So somehow by decreasing osteoclast activity, you're also decreasing osteoblasts, and you are basically decreasing the whole appositional growth characteristics. Sorry, I should have just put this at the end. I apologize again for jumping around. So, bone remodeling, again, this growth here of what happens during bone repair, just something kind of general that I wanted to say about it before we get into a little bit of the details of it, is the bone growth that happens after a fracture is a lot more similar to the intramembranous bone growth that you see during development. Again, what you're using is, after you get a break, you're using the existing bone as a substrate for adding new bone tissue. Right? But the way that this actually forms, you'll see this term here of woven bone. Right? The initial bone that's laid down is much more like the initial intramembranous bone that forms. Okay, so in general, the healing process starts off a lot like intramembranous. Again, what stimulates the area, kind of like similar to developmental processes, right? What stimulates the process is the formation of a blood clot in the area. Right? A blood clot in the area, you know, we talked about blood clots in response to wound healing in the skin. Right? A blood clot's going to actually give the skin a little bit of stabilization. Obviously, blood clot in broken bone isn't going to be enough to provide any structural support. But what it does is to start to stimulate the cells in the area, right? So that you actually get this cartilage that starts to form, right? And at the same time the cartilage is forming, you're getting some bone growth. Right? The callus here, right, refers to both the cartilage that's being inserted into the bone, as well as the bone material, the woven bone material. Eventually, that cartilage is going to get replaced by a lot of bone tissue. Right? So you have this initial reaction that's much more like developmental processes. Right? So this part of healing is what typically takes. How long does it take? How long does it take for a bone to kind of structurally heal so you can start?
4 months, 6 weeks.
4 weeks, 6 weeks, something like that. Right. So this process here, to where you actually get a strong, something strong enough to put weight on, right, takes like 6 weeks, 4 weeks, 8 weeks, somewhere in there. This process here, right, is a much more longer term remodeling. Right? If you've ever broken a bone where it happens to be exposed, right, you can feel you've got a bulge there probably after a few weeks. The whole central canal of the central marrow cavity has been filled in. And then this process here, which is much more like the typical appositional growth of bone tissue, takes months to years to completely heal. Again, it's not unlike skin regeneration after a wound, right? You get a big cut, right? It heals up really well, but you've got all this scar tissue that's in there. Slowly, over the course of months and maybe even years, the scar tissue slowly gets destroyed and remodeled, kind of similar to where this callus material real slowly over time gets replaced. Just like yesterday, it's kind of good to end this section in the middle. I decided it was good to end the chapter in the middle. It wakes you up a little bit, doesn't it? Hopefully, an hour and 10 minutes. You guys know the psychology of typical attention spans, 20, 30 minutes at the most. Yeah. I am going to go through all of this material. But what I'm going to do is kind of start in the middle. I've got if you've got the PowerPoints, you'll see I've got a bunch of stuff talking about technically the joints between bones of the skull and like bones of the ilium and the pubis, where it's completely fused together, and some of these other kind of what you think of as atypical joints. What I'm gonna do, because it kind of relates more to the skeletal anatomy that you guys are focusing on, I wanna get through just talking about the motion of joints and go into a little bit of specifics about motions of the knee joint and the shoulder joint. So I'm gonna start there, and we'll go back and pick up the definitions of these terms. All right, so I'm gonna skip over this designation of fibrous joints and cartilaginous joints, and really just go into the main description of synovial joints. So hopefully this should be pretty familiar to you. It's something that you've already thought about. What synovial joints technically are, right? There's hyaline cartilage. You can't always see this in all the bones that you're looking at, but hopefully you know that in life there's a layer of hyaline cartilage on the ends of both bones. Right? Sometimes in some joints there's a layer of fibrocartilage, right, that's present in the center of the joint. And when we get to the knee joint specifically, we'll talk about this other thing. Right? So that's what's technically in the joint, and then surrounding the joint is this synovial membrane. There's a synovial membrane. The synovial membrane is a simple cuboidal epithelium. And the epithelium of the synovial membrane is actually the site of synthesis of the fluid that is filled in the joint. The fluid is necessary just kind of for lubrication of the joint. This is a closed space within the body. It's relatively free of vasculature, which is part of the reason that joint injuries can take a while to heal, whereas bone injuries heal a lot faster. So the synovial membrane is this real thin membrane that's kind of shown in blue here, simple cuboidal epithelium, right? And then surrounding it is a dense, regular connective tissue, right? That kind of acts as a structural support, mainly for the synovial membrane. Right? So that's what technically is the joint. We talk about ligaments and tendons, right, which are a thicker, dense, regular connective tissue surrounding the joints. Those technically aren't part of the joint structure. The joint itself is just everything inside of this fibrous capsule. And I want to get to this stuff just about motions of joints, so I'm going to skip over the clinical correlation of rheumatoid arthritis. I'll come back to that on Monday. So one thing that I'm kind of giving this to you, mainly just so you think about joint movements, probably something you've already been thinking about, but I want to go over it before you get through the lab exam, just to kind of help review. One thing to say, your textbook goes into the names of all these different types of joints. What's a glide joint? What's a ball and socket joint? I'm not going to test you on that kind of stuff. And again, what I'm talking about here, what I'm going over here, isn't the type of stuff that I'm going to surprise you with on the lab exam on Monday. But I just want to kind of go over it. I will talk about, I will ask you questions about the motions of joints, which is something that you've probably already thought about. If you haven't thought about it, now's the time to really put it together. Now that you've memorized the bones. Think about the way that the joints are moving. And basically, for every joint, every synovial joint in the body, especially when we start talking about muscles, we'll talk about the motions of joints. What I want you to do, and I'm not going to systematically go over every joint in the body, but what I'm going to do is define some of these terms as far as which joints move in which directions. Right? And I want you to use these anatomical terms, which you may or may not have had before. Flexion and extension, pretty simple. Right? No, almost every joint can be described as flexing or extending to some degree. Right? But it's kind of a goofy definition because it doesn't always hold true with every joint, right? But the definition of flexion, you guys, I know a lot of you guys are, what's the definition of flexion? Decreasing the angle between two joints, right? And we'll get into some examples where that's kind of a goofy term, but technically, at least at an initial level, right? So think about, this is, just this. I mean, you guys know, flex your biceps muscle, flex your arm. That's, decreasing the angle between two joints. Okay? And then extension is basically just the opposite of that, right? Flexion and extension. There's some other things that flex and extend that don't necessarily fit that, right? You can go through the wrist joint, right? Wrist flexes and extends, right? Well, that's not really decreasing the angle, but if it's if it's in that same direction, right, it's classified as flexion. So this is flexion, and there's a table in your textbook that goes through every joint, right? But just so you kind of get the generalities, flexion and extension. It's worth it just to describe these other joint movements, right? Because you think about the shoulder joint. Shoulder joint's really complicated. Shoulder joint can do all kinds of things. I'm gonna try to break it down. I know you guys, some of you, especially the exercise science, that have had a lot more detail than this. But I'm just going to break down. This is what your shoulder joint does: flexes and extends. Right. So again, I think I forgot to go over anatomical position. Right. That's something that's in chapter 1. Right. So anatomical position is for a patient standing in this orientation, not like this. Like this, and then you can describe flexion and extension, right? Abduction. What's abduction mean? AB. AB is away. Ab is away from the midline, right? So the midline's here. Abduction is away from the midline. So your shoulder joint can also abduct, right? And then adduction towards the midline is the opposite of that. Other joints that do that. Abduction, right? Again, it's kind of confusing when you just kind of think about this, but you always put the body back into anatomical position. So abduction, movement away from the midline is this, adduction is towards the midline. So, for the shoulder joint, similarly for the hip joint, that's all they do. You guys know, there's more fine details. You can talk about the rotation of the shoulder joint, rotation of the hip joint. I'm not going to get into that much detail. For what I want you to know, right, and it kind of relates to the main function of muscles that we're going to talk about. Think about the joints in the body that are doing these big functions: flexion, extension, abduction, adduction. Right? And there's this term that I don't like using. It's called circumduction. It's really just a combination. These ball and socket joints can circumduct. But these are the motions that I want you to concentrate on. Pronation and supination in anatomical position of the hand. So this is a technical term that just refers to the forearm, right? Pronation. You guys that are runners, you've heard of pronation and supination in your feet. Technically, there's different terms for movements of the ankle joint. So anatomically speaking, pronation and supination just refer to this motion here. Right? So anatomical position, the forearms or the hands are in the prone position, right? Supination is rotating over pronate. Oh, I got that wrong. Damn it, I always do that. Anatomical position is in the supine position. Pronation is, you know, rolling the palms. Technically, you'd say moving the palms posteriorly. Supination is the opposite of that. Elevation and depression. These refer to movement of some specific joints. The mandible can elevate and depress. Think about the motions of your shoulder, of your scapular joint. Yeah. So your shoulder, right? Stretch up your shoulder. If you think you're moving that's not your shoulder joint that's moving. What's moving? The scapula is moving, right? So you're elevating the scapula or depressing the scapula. Mandible can elevate and depress. And actually, I forgot. You do have medial and lateral rotation. I'm not going to get into a lot of specifics of this. Dorsiflexion and plantar flexion, as well as inversion and eversion, refer to the ankle joint. Right? There's lots of motions right here in the carpal bones. Right? There's similar motions, not as much, but there's some motions in the tarsal bones and the metatarsals. We're not going to get into those. Right? But these motions here specifically refer to the ankle joint, right? The movement's right there at the end of the tibia/fibula, right? So dorsiflexion, the dorsal. This doesn't really ever make. There's really not a good reason for why it's called dorsiflexion, right? Dorsiflexion is picking your toes up, right? Plantar flexion, if you think about it, kind of makes sense. The plantar surface of your foot, if you flex your foot towards the plantar surface, right, or the calf muscles, right, that's plantar flexion. Dorsiflexion is the opposite of that. And then there's this inversion and eversion for your feet, right, moving the foot in, which is really rotation around that ankle joint, right, inversion and eversion. I thought I was going to have more time. That's okay. We can cover the rest of the joint stuff on Monday. I just wanted to get through these. Again, I'm not going to test you on this on the lab exam. Hopefully thinking about those joints and which joints move in the correct direction. Studying both.